thank you so much, everyone, for joining us today. Welcome to today's webinar, Thrive, Not Survive, a deeper look at burnout. Thank you for joining us. I'm Sarah Cameron, Senior Director of Professional Services and Senior Consultant at the Hardenbergh Group, and I will be your moderator for today's session. Today's webinar is being sponsored and hosted by the Hardenbergh Group. Just advance my slide. It's not working. Got it. All good. So before we begin today's program, I'd like to share a few housekeeping details. All attendees' microphones have been muted for this presentation and chat has been disabled. To ask the presenters a question, click on the Q&A icon located on the navigation bar at the bottom of your screen. It might be at the top of your screen, and type your question. We will have several interactive slides during today's presentation, so please have your mobile phone, your cell phone, your camera ready to scan those QR codes to participate. You can also participate via menti.com. That's MENTI.com. When we get to those slides, there will be a code for you to enter on the menti.com site to use that slide. At the end of today's webinar, as time permits, I will review some of those questions submitted through Q&A, and we will ask Dr. Thompson to weigh in on those questions. In today's presentation, we are required to inform you that we have no disclosures for today's presentation. NAMSS continuing education credit will be emailed to you within 24 hours directly from Hardenbergh in your thank you for attending follow-up email. Also included in the email will be slides from today's presentation and a link to a short survey. We hope you will take a few minutes to share your feedback. If you're seeking CME credit today, please watch your inbox for a CME evaluation to complete. Once you've completed that, your certificate will be emailed to you as well. Now, it's my pleasure to introduce Di Thompson. Dr. Thompson is a nationally recognized psychiatrist with over 25 years of clinical experience in her role as a system-wide well-being medical director. She has developed a diverse well-being program to support physicians and advanced practice providers, including annual burnout assessments, which you'll hear more about, and a robust peer coaching program. This unique program has demonstrated improved provider burnout rates and has grown to include over 300 trained physicians and APP coaches. And now, I'd like to turn it over to Dr. Thompson.
Good morning and good afternoon, everyone. It is such a pleasure to be here today, and I'm so excited to talk about my absolutely most favorite topic in the world, and that is physician well-being. So to start today, let's go over some of the goals for today's session. By the end of the session, we will be able to differentiate between individual and organizational burnout. We'll talk about the different symptoms of burnout and how to identify those. Then we'll talk about the ramifications of burnout, acknowledge the importance of feeling valued, recognize suicide risks, and explore solutions to actually combat that burnout. Now, I know all of you have been warned that we're going to be asking you some questions along the way. And I'd ask you to take out your phones and get ready for the first question. My first question is, tell me, when you think about burnout, when you hear that word, what do you think of? What words come to mind? What emotions do you feel? What's going on in your head when you think burnout? So please start telling us great, overwhelmed, stressed, exhausted, procrastinating. I love it. Sadness, yes. Anxiety, frustration. Great.
The way the words flow in feels a lot like how burnout feels, doesn't it?
Absolutely, absolutely. I like the done. I like that one. Tired, exhausted, overwhelmed. Wonderful. Well, as you're putting these in, I deal a lot with physicians, both in groups and one-on-one. And when I ask them what emotion comes to mind when you hear the word burnout, over and over again, they tell me the same word, And that word, it's angry. Yes, Vicki Ramos, you pegged it. Angry. Now, some of you may be thinking, why angry? Well, let's talk about that. When physicians hear that word, they feel like it's personal, like it's a very personal attack, that somehow they're not strong enough. They don't have enough stamina to deal with the situations that they're going through, that they aren't resilient enough. And I can promise you that anyone who's been through medical school and residency has a whole lot of resilience. So what else is going on here? Let's go to the next slide because I'd like to talk about the elephant in the room. So for years, we've just been talking about what I call individual burnout. But there's more to it. There's a lot more to it. There's organizational resilience as well, and the two go hand in hand. Health services need to move beyond encouraging just this personal resilience by providing appropriate system-level interventions and support mechanisms. This will not only enhance that personal resilience, but it will also enhance the resilience of the entire system. So let's talk about the different domains of organizational resilience in healthcare. First off, there's organizational commitment. And now later on, we're actually going to be coming back to talk about what can we do about each of these specific areas. But just first to go over what they are and identify them, organizational commitment, workforce assessment. We need to figure out what's going on to assess what are the needs of our physicians. Leadership plays a huge role. We need to explore policy. The efficiency of work environment. Are we making it as easy as possible for physicians to get their work done? And then what kind of supports are we offering? That slide really speaks to one of our objectives for today, which is differentiating the two types of burnout. Let's talk about some of the consequences, because with burnout, we may see things like a change in ability to do some of the administrative duties that physicians are tasked with. We may see them having more difficulty with challenging patients and families, perhaps saying things that they normally wouldn't do, having that shorter fuse. Conflicts with colleagues, being shorter or less tolerant with those around them. And then the two definitely overflow. Stressors at home and stressors at work can't help but combining. And then we're all still dealing with some of the fallout from COVID. And the last kind of stressor that's going on right now is that geopolitical climate, the turmoil that's going on. Can't say enough about how that has affected our physicians, and I think everyone. As we're talking about that, that leads me right into one of the things that I think a lot of people are experiencing. And that is one of the facets of burnout. Maslow came up with three particular facets that kind of define burnout. These are the symptoms that we see and look for in all the surveys that we do and when we're trying to recognize burnout. The first is emotional exhaustion. And this is just feeling absolutely drained, both physically and emotionally. Depersonalization is almost feeling kind of numb, just not being able to even get that empathy, rather feeling callous, sarcastic, sometimes even resentful. The other thing that suffers when someone is burnt out is their ability to feel like what they do every day is as important as it really is. So finding that work meaningful, does that still matter to them? Or are they saying, what's this all about?
Dr. Thompson, is this a chronological, like, do we see these
Hmm.
same patterns as we do in grief or other things? Is this escalating, or can you have all of these and none of these and still be
Good.
burnt out?
Right, good question. They don't have to go one after the other. In fact, they usually don't. So, for example, someone can actually feel really good about what they do. They love their patients and taking care of them, but at the same time, they might be incredibly emotionally exhausted and drained to the point where they're not able to take care of themselves, especially after they leave work.
Sure.
Yeah. We're not the only ones, though. This is actually a universal issue. Sarah, let's go to the next slide. There was an interesting study done in 2020 that looked at 60 different countries. And over half of the providers overall reported some degree of burnout. Previously, the rates had been between 43 and 48. At that time, and again, this was just as COVID was starting, burnout rates were fairly consistent. However, the US did have the highest rate at 50%. Burnout during COVID was associated with feeling like they are pushed beyond their training, doing more than they were trained as residents and attendings to do. Super high workload, making life or death prioritizing decisions so many times each day, super high stress. And then their work impacted their ability to come home and be able to do anything. They were working so many hours. There was also the fear that they were going to bring COVID home to their families. And there was lack of adequate PPE, with limited organizational support, not always due to a particular fault of the organization. So the good news is we have seen that burnout rates have fallen. They were 56%, that was the highest in 21 at the peak of COVID. In 23, they dropped further. And now in 2024, because we don't have data yet for 25, the burnout rates have dropped to 45%. Now, you may say, oh, hey, that's great, they've dropped. But let's think about that number. 45% of physicians are still reporting significant burnout. So, what causes burnout? Well, we know that there are some key indicators that represent what we can do to have a resilient physician group and a resilient hospital organization. So one of the things is satisfaction. We look at how satisfied physicians are with their jobs. And this data comes from the 2024 National Organizational Biopsy through the AMA. They looked at the role of satisfaction, stress, burnout, intent to leave, and the feeling of being valued. And they found that most physicians nationally are satisfied with their job. Now, that actually probably shouldn't be a big surprise because physicians went into their specialties because that's what they wanted to do and they want to help patients, right? So satisfaction makes sense that it's still pretty high despite burnout. And then there's stress. 45% of physicians report that they are under a significant stress. So perhaps more than what they expected, even knowing they were going into high stress jobs. And then the AMA reported in 2024, which is slightly different from the other reporting, reported a burnout rate average of 43%. So 45, 43%, somewhere in that range.
So, Dr. Thompson, I wonder as we look at the rates from 2020, when we all know burnout was present for all of us, really, it was just a crisis in all regards. But do you think that the rates have fallen because we've left the times of the pandemic, or do you think that they're falling because we've normalized the culture of being burnt out?
That's an interesting question. I think it's a combination.
Yeah.
The I think the physical burnout that physicians were experiencing during COVID has probably been replaced with more of the emotional
Mm, yeah.
exhaustion that they're experiencing.
Yeah.
Which leads me to a number that makes me very nervous, and that is the intent to leave. A third of physicians say they're either thinking about or have decided that within the next couple years, they're going to leave the profession.
Mhm.
If we think about what's going to happen in the future, we're not going to have enough doctors unless we do something about this. Now, that number makes me nervous. The next one just makes me sad
Mhm.
because I would want every physician to feel like they're valued by their administration. Unfortunately, about half of physicians really don't even feel like their administration appreciates them or understands the significance of what they do. So, is it different with different specialties? Not so much. If we look overall, we can see that again, most physicians are satisfied with their jobs. They like what they do, but they're under a lot of stress. And this goes to the whole idea, Sarah, of what you asked earlier. Does one have to follow the other? And it doesn't. But if you look, you can see that OBGYNs, for example, they love what they do, but they're pretty darn stressed out and burnt out. The intent to leave is about the same, with surgery being a little bit higher than the others. And again, that feeling valued, and we'll talk more about that, why it's so important, and perhaps some things that we can do about it in the future.
It's interesting to me that the intent to leave is higher in the fields that are procedural versus the fields that aren't procedural. It's just an observation. Um,
Right.
yeah, interesting. Very interesting.
It is. And we can probably come up with some ideas about that,
Yeah,
including just the physical work that is involved. Right.
right. Absolutely. And access, I think you have to do a lot more of arranging when you have to schedule procedures and perform procedures. And there's probably more
Exactly.
barriers to those providers as well.
Yep. Yep. Let's talk a little bit about gender and burnout. The AMA, the American Medical Association, had about 12,500 responses from physicians across 31 states and 81 health systems who participated in a survey about women versus men and burnout. And women physicians were much more likely to experience burnout, 55% compared to 42% of men. They also felt less valued. The percentage is somewhere around 46% of women feel valued versus 56% of men. Again, both too low, but something we need to do something about.
So
And then there was a study. Oh, go ahead, Sarah.
no, I'm just curious, thinking about how men and women, how there are different stigmas around burnout and mental health and the things we struggle with. And I wonder if this is because women are more likely to report that they're experiencing burnout than men are, or what your thoughts are on that.
All these surveys are confidential. So I think people are pretty honest when
Okay.
it comes to it. There may still be some discrimination
Hmm.
with women. Another thing we can think about. I know every time I talk to groups of women physicians, somewhere along the way, the conversation comes to the fact that we are often approached by patients with the, "Hey nurse, can you get my doctor?"
Yeah.
Actually, I'm your doctor.
Yeah.
And then I do want to highlight the LGBTQ population because they actually have even higher rates of burnout than what we've discussed so far, have less professional fulfillment, and are even more likely to leave their practice. So, when I first started working with physicians one-on-one, in Colorado at least, those that were burnout always used to say, "I just want to quit my job and open a bike shop." Now, maybe different in different regions of the United States. Maybe everybody doesn't want to open up a bike shop, but they were thinking about it. In the pre-pandemic, it was those 40 to 54-year-olds that were reporting the highest degree of burnout. Interestingly, now we're seeing more distress in the 35 to 45 range. And again, we can only guess, but it may have something to do with being more of the sandwich generation at that point, having children that are definitely old enough to go to all those sports games, but maybe not old enough to drive yet. And again, there could be a lot of other reasons, but just something for you all to think about. So despite women feeling less valued and despite them being more burned out, they actually are less likely to leave the profession than men. However, there's a
We're loyal,
caveat.
Dr. Thompson. Women are
I'm,
loyal. We are
yes,
loyal individuals, and
there you
we tend to
go.
be loyal.
Well, that's the reason then. Although there is perhaps another reason. And that is, according to the AAMC, which is the Association of American Medical Colleges, within 6 years of completing training, 23% of women physicians were not working full-time, compared to about 4% of men who are no longer working full-time. The gap expands even more between women who have children, goes all the way up to 31%, again, versus 4% for men. So, cutting down on time and certainly leaving costs a lot of money. Losing just one physician can cost anywhere between $500,000 to $1 million. And it's getting closer and closer to 1 million or more, particularly because not only does this affect the physician void and what you need to do to replace someone quickly, but also all the recruitment expenses. We want to keep our physicians healthy and we want to keep them at our hospitals. So I would urge you to think again about the symptoms. You might notice relationship changes. People just not acting themselves, making more errors, absent more often, just not showing up for work or calling off. Presenteeism. I don't know if everyone's familiar with this word, but it basically means going to work but not really being there, just kind of going through the motions. Reduced productivity. And that may be something as simple as they're so burned out, they're just exhausted doing the basics, completing their charting. Substance abuse can be something that goes along with burnout. We saw an increase definitely during COVID. We talked about turnover. And not only physicians leaving one hospital to maybe work someplace else, but leaving altogether. So burnout really does have some significant consequences for the individual. And I'd like you to take a minute to just think about a physician that you really like. Just one of those docs that's just a really good guy or a really good woman. And now imagine that they are suffering from burnout. Well, they're at a higher risk for a whole lot of really bad medical issues if they're burnout. Hypercholesterolemia, type 2 diabetes, coronary heart disease, musculoskeletal and other pains, prolonged fatigue, more headaches, they get more GI issues, respiratory problems, they're more prone to injuries. And this is the terrifying part. They are more likely to die below the age of 45. Now, if
This
you're
one
still,
really hit me. This one hit me, Dr. Thompson, as someone turning 45 this year. That hit me hard. That is so young. Probably not as young as it felt to me 20 years ago, but so young to have your life, your mortality increased by your profession is just, it's alarming.
it is. And as you're thinking about that physician that you really like, I hope you're thinking, oh my gosh, what can we do about this? Well, there are some things we can do. So let's start with that feeling valued. I can't tell you how often physicians say that they just feel like they've never seen some of their administrators. I was just talking to a surgeon from a different hospital organization altogether. And she said, I just wish that someone from administration would come and walk in our shoes for a day, just see what it's really like to be in the OR and what we struggle with. Now, there are some programs that actually do that. And I'll be happy to talk a little bit more about that later on. But let's talk again about the importance of this. Women are less likely to feel valued, we talked about, than compared to men. And what does this mean? Well, those that feel less valued also are more likely to feel more burned out. Now, I would be remiss if I did not talk about this very important topic, and that is suicidal ideation in physicians. Terrifying. The newest data shows us that 1 in 6 physicians have contemplated or attempted suicide. And that's risen from 9% in 22 and 23 to about 15% in 24. Almost 40% of physicians say they knew at least one or more of their fellow physicians who had attempted or thought about suicide. And that's data from this year. And then the National Violent Death Reporting System data reports that the suicide risk is particularly high among women. It's a staggering 47% higher than compared to non-physician women. Interestingly, male physicians had a slightly lower risk than their non-physician counterparts. However, 1 physician lost to suicide is too many. So let's talk about some of the solutions. What can we do to prevent burnout and improve resilience for the individual and also for the organization? Well, let's think a little bit. Actually, let's do a word cloud again.
Oh, Let's get into it. Sorry about that. I was having a little tech issue there. So I want to pull in our MSPs into this conversation because we're talking a lot about our providers and in different ways that we can support them. So I want to just bring your awareness to your own knowledge. So what is the most common credentialing red flag that you encounter in an application? I'm just curious where we fall with these. So let me move this QR code so you guys can see all of the different categories. So we've got criminal history, malpractice claims history, and gaps. Oh yeah, definitely seen malpractice claims history. I bet you all could have probably listed 4 or 5 additional common red flags that you see in these applications pretty often. If I had to guess, we get some colorful things, right? Yeah, so I'm seeing lots of malpractice claims history, but the point is you all immediately knew what a red flag in an application is, right? You can spot those in your sleep. It feels like I could look at a CV and probably spot red flags at this point. So let's try it again. Let's go to a new QR code. Let's scan this one. Name a sign that a provider is experiencing burnout. Give me a burnout red flag. Annoyance, irritable, anger, neglect, anger. I'm seeing a lot of anger. And right on, that is exactly what I would have definitely used the word anger, short temper, irritable. One of the reasons that I wanted to bring this to our attention is we as MSPs, we see these behaviors a lot. Sometimes we're the first to see them because we're that paper pusher who's always on top of a provider to give me something new, sign something new, give me something new. And we're the first to see those behaviors start to slip. We're also the first to see incident reports a lot of the time. So if you have a medical staff office that addresses peer review or burnout or professionalism, you get these incident reports and we're often the first to see them. I like to tell this story about, I had a provider, it was an ER physician, shift working physician. We'd get a few reports on him, usually patient complaints. He wasn't very nice to me. He kind of treated me like a drug seeker. And I'd get these reports and we'd have a sit down cup of coffee with one of our medical directors and things would get better for a little while. And then we'd slip back and then they'd get better. So he and I got into this pattern of having a lot of conversations. Even if the chair wasn't free, he'd stop in and he knew when an incident report came in and he'd come and sit down in my office and we'd talk about it in addition to the formal process. And one of the things I finally said to him is, what's going on? Because you are able to self-correct for a while and then you're not able to self-correct. What's going on? Like, are there things going on with you? Are there circumstances? And there were a few personal things that he could point to, but the majority of it he pointed to was, when I get to the end of working 12 straight, when I've worked 7 straight 12-hour shifts, I'm shorter. I just don't have it in me to be as compassionate and empathetic. And I said, well, how about we make a change and make sure you're not scheduled for that many shifts in a row going forward? If you have identified that as something that really beats down on your burnout and beats down on your ability to deliver care with the compassion and empathy you want, let's change the situation a little. So it didn't take more cup of coffee conversations. It didn't take corrective action. It didn't take suspensions. It took somebody saying, what's going on with you? How can we help make this a little bit better? So I really want to encourage you as med staff professionals and to our physicians listening to ask, how are you? Be a conduit to allowing someone to share. So we're often the first to notice. I've kind of covered all these while I left the word cloud populating because I think it's so cool. But we're the first to notice credentialing and reappointment processes often surface early signs of distress. Gaps in work history could be a sign. Delayed response is definitely a sign. We are trusted eyes and ears to the physicians. Not only are we gatekeepers of patient safety, but we're also gatekeepers of their profession a lot of times. And they trust us. They know that we're a valued colleague to come and sit and talk to. I think they know that we lead with compassion and empathy, and they're seeking that from someone. And then system navigators, we as MSPs, we are employees of the hospital, maybe in addition to the provider, maybe the provider is a contracted group, but we know how to navigate our system to the EAP, to the wellness committees, to the resources that will help us improve rather than things that are scary to us. If I'm experiencing burnout at work, of course, I'm concerned that my boss is spotting it and worried about me. We as MSPs know the way to find the resources we need so that it doesn't have to be a concerning, scary thing when we aren't performing at our best. So I just want you to all ask the question, what if credentialing professionals were trained to spot burnout risk factors the same way we identify red flags in an application or a reappointment or other credentialing actions? How could we support better?
I love that, Sarah. Thank you. Now, if you remember at the beginning of the presentation, we looked at the different areas within organizational resilience. And the first one was organizational commitment. Can't stress enough. We need to get buy-in from those key leaders, C-suites, board of directors, letting everyone know what an important issue this is and that we need their support. Leadership can play a crucial issue. At times, there may be barriers that really can be removed, or resources that, despite a limited budget, might just make the difference. So the next part to the organizational resilience was a workforce assessment. It's important to measure how your physicians are doing and hopefully see an improvement over time, but also to see what the areas of the stressors are for them. And there are multiple formal measurements. Two of the most common are the Maslow Burnout Scale. This is a 22-point question. And again, I urge you, if you do use these assessments, to make sure that they are confidential and don't include the physician's name. The other one that I use is the Mini Z. Part of the reason why I use that is because it's a little bit shorter. It's 12 questions, and it's supported by the AMA. They actually will hand out the survey to physicians or send them the survey through their emails, totally confidential, and then they analyze the data and then get back to the institution that is performing the survey.
Dr. Thompson, as you've worked with different medical staffs to develop these measurements for well-being and burnout, do you get resistance or do you get excitement from those medical staffs? Are they absolutely on board and like, yes, let's do this? Or do you ever run into medical staffs that are kind of like poo-pooing the well-being and the burnout? I'm thinking of my own experiences, and there were definitely medical staffs that would be like, we don't need any of the hippy dippy well-being stuff. Not saying that it is, but those are the comments that I would hear. So curious if you have suggestions on kind of overcoming that, or if you've seen it.
Sure. So I saw someone asked about that survey, which is the Mini Z. So there are a couple pieces to that. One, there are other surveys that we often do, engagement surveys like the
Mhm.
Press Ganey or others. So some of it is just survey fatigue.
Yeah.
I think it's important, again, going back to that leadership piece, that the message comes from leadership that the reason we're doing this is because we want to make changes that best suit you,
Yeah.
that help you. And if they can send that message, I think physicians are more willing to do the survey. Also important just to interview physician groups and see what they have to offer, because they may have some great ideas. And then checking in with things like pajama hours, inbox volume. How do they handle that? Are they able to delegate to their MAs and others? If anybody's wondering about pajama hours, that's when a physician works all day, comes home, takes care of the family, gets them tucked in, put on their PJs, and start charting and chart till midnight.
That sounds like
That's
MSP hours as well.
well, as I'm sure you can imagine, it's not good for you and is
No,
going to cause burnout, right?
absolutely. Absolutely.
Then let's talk about leadership. And we had mentioned that previously, even with the Mini Z and getting support and encouragement from leadership, leaders need to be present and accessible. I talked about the one physician who said, I just wish one of the administrators would walk in my shoes for a day. There is a program that some hospitals use called Suits to Scrubs. And this is where the C-suites literally once a month put on scrubs and meet with the surgical team, the medicine team, the hospitalist team, and sometimes they meet with non-physicians. Maybe it's the dietary team. And then when they're done spending the day, they recap that in a little paragraph or so that they send out in a newsletter to the hospital. Really makes a difference.
Mm.
Conflict management. This is important. Conflict is not fun. However, it can be really helpful. And leaders have to feel comfortable engaging in, with an open and curious mind, some of those difficult situations and conversations. They also need to foster an environment where people feel safe communicating and understand that flexibility is something that might be helpful, particularly with physician schedules, and be adaptive. Encourage innovation and problem solving because physicians sometimes have some really good ideas. The next piece of organizational resilience was policy. And I'm sure many of you are familiar with the Dr. Lorna Breen Health Provider Protection Act. Because of this, the Joint Commission does not require organizations to ask about a clinician's history of mental health conditions or treatment. This really has a stigma to it. So I encourage you to revisit your existing policies and procedures to just take a look at what you have on that application.
I just want to make a comment on this, Dr. Thompson, that in whatever state you're in, be aware. I know that there are a lot of state mandated applications. I know that this is a big conversation happening among the states. Just be patient with your states. I know that there is an intent to relook at those state mandated applications, but you can also be looking at your policies within your own organization. So if burnout shows up in our workflows, then well-being should show up too. I love that saying. If you can burn out, you can also burn up, I guess. Is that a new saying? So from credentialing to compassion, I kind of hit on this a little bit with the last slide. We are very much gatekeepers of patient safety. That is our tagline as medical staff professionals. And we take that very seriously, and we expect to be a gatekeeper. But I also just want to encourage all of you to be an advocate as well. There is such a space for being an advocate for our physicians. And we don't often think about reaching out to leaders, and physicians are often seen as leaders in in our care teams. You don't reach up very often to make sure people are doing well, but you do reach out to your fellow team members or those who you're supporting. But I would encourage each of you to make more of an effort if you're seeing that little bit of agitation, or you're seeing someone really express that they're struggling in any way, to ask those questions. And it just looks like, hey, how are you doing? Hey, want to sit down and talk and grab some coffee? What kind of struggles are you having? Just creating a knowledge to the provider that you are there to listen when they do want to come to you is incredibly valuable.
Thanks, Sarah.
Yeah.
Let's talk about the next category, which is efficiency of work. So really think about it, minimizing administrative work. So many physicians say, if I just didn't have to do so much inbox and secretarial work, I could get everything done by the end of the day. Really encouraging that teamwork and minimizing technology-focused tasks for physicians. And then support. It's important to create workflows that really prioritize that teamwork and efficiency of care. We know that programs where physicians and the rest of their team feel like they're working together, there's less burnout. It's important to create community at work. This is one of those really big components that actually prevents burnout, and that is making physicians feel like they're part of a community and not just a cog in a wheel. And then leaving work with enough physical and emotional energy to take care of themselves. Super important. And consider offering mentorship programs as well. So going back to that idea of home and work and the overflow between the two, I'd like to tell you a story. I coach physicians all day long. And one day a surgeon said to me, just by the end of the day, I am so exhausted. By the time I get home, I open the door and my wife has 1,000 words to tell me, and I've already used my 500 up. He was so earnest about this that he said, well, hey, wait a minute. You know, in my clinic, that's when I could be on. So maybe like if I had her make an appointment at 10 a.m., she could come in and we could have a really good conversation. Yeah, that's probably not going to work. So let's move on to what are the components of an effective well-being program? Well, it's very important to have a chief wellness officer, someone who can oversee the program and make sure that these components are running. Peer coach training is extremely important and very productive when we think about ways to prevent burnout. And I'm happy to talk to you more about that. Also consider a 24-hour hotline that's just specific for physicians. You may find that the physicians are using that. Some institutions may find that their physicians really aren't using it that much, but just the fact that it's there makes a difference. Consider having a way to work with groups to have conflict resolution between individual physicians and with others that they work with. And then the piece about building community, whether this is done through having peer coach training programs or things like commensality meals. This is a program that was initially created by Mayo that encourages groups of physicians that might not even know each other at a hospital to meet for dinner with one person kind of asking some general questions, things like, how do you support your significant others when you're under stress with work? Or what's the latest book you read? If you do evening events and are thinking about, oh, we should do a physician social, I encourage you to do that with the significant other, because the last thing somebody wants to do is leave their family at home at night after working all day. And then encouraging some other activities. At some institutions, they actually give credits for doing things like volunteer work. And it's important to use metrics to figure out, is this program working? And that may be through some of those burnout scales that we talked about, as well as engagement scores. I want to take just a minute to talk about peer coach training because I am passionate about how this improves the overall community of the hospital and physicians and burnout, not only for physicians, but for nurses and others. So at my system, we have well over 300 physicians that have gone through a training so that they learn how to better recognize and support their physicians that are experiencing distress. On the mini Z this year, we asked, one of the questions was, have you been through the peer coaching program, yes or no? And we found that physicians who had been through peer coach training, who had just got the training, had such a high satisfaction score, were less stressed, and look at their burnout scores, almost a third of what the national average is, and certainly feeling more valued as well. So speaking of value, what can we do to make physicians feel valued? Let's move to the next slide. Because we don't want them to feel like a cog in the wheel. Well, flexibility, perhaps working at different times, starting earlier, leaving earlier, really letting them know you're thinking about these things, encouraging them to take vacations, and asking about what do they want to get out of their career? Do they want more professional development?
So I'll quickly just say I've said all the things on these slides, and you will get these slides after the presentation today. I've seen lots of questions about that, but we should be training our fellow MSPs to spot the signs of burnout. Encourage them to watch this recording or read the slides. Include MSPs in your wellness committee. We're not just minute takers. We really have a deep knowledge of policies, bylaws, and opportunities and tools available under the med staff continuum, and then empower MSPs to ask, are you okay? I think that's just a powerful thing. I think we should be asking each other more in general. This doesn't just apply to physician burnout. I think we should really feel empowered to ask each other, are you okay today? Do you need to talk? And just working that into your daily life makes a big impact on you and the people who you say it to.
Thanks, Sarah. So, with suicide prevention, let's do everything we can to reduce the stigma. I encourage you to train your leaders to recognize symptoms of distress and depression in their colleagues and in their physicians and other providers. Consider things like HRO training, high reliability organization training. And if you can do live versus pre-recorded modules, everyone gets so much more out of that. And then make it easy to identify state-led physician health programs. These are nice because they're not affiliated with a specific hospital and confidential, as well as things like your own EAP program. Maybe consider asking local psychiatrists if they would be available if you have a physician in crisis. Nice to have somebody on hand for that. So let's summarize. So today, you've discovered, if you hadn't already known, that there are two types of burnout, both organizational and individual. The cost of burnout is staggering. We want to keep physicians as healthy as possible. And by recognizing and instilling a sense that physicians are valued, allows for improvement in the culture, lower burnout rates, better job satisfaction. We need to make sure suicide prevention is a basic tenet of every well-being program. And special attention should be given to some of those high-risk groups that we pointed out, including those with any mental health disorders, women, and transgendered individuals. So I'd like to end today with the next slide, because what you all do is stressful too. Talked a lot about physicians and what they are going through right now, but understand that administrators experience significant stress and can definitely get burned out as well. So I encourage you to take a minute and think about what you're going to do today, just today, to take care of yourself, because you really can be a role model for your providers. So thank you, and please take care of you.
Thank you all for joining us today. Just a couple comments. My email address is on your screen right now. Also, this is a QR code. If you want to scan, obviously you've scanned several throughout our presentation, but if you'd like to scan this one, this will take you to a link to grab time directly with me. If you have an interest in developing a peer coaching program, a wellness program, anything that we've talked about, if you need support in any realm of med staff services, we are here to help you, and this will give you 15 minutes with me to talk about what you have going on and how we can support you. I can also get you linked up with Dr. Thompson if you're interested in developing any of the resources that she talked about today. So I'm going to jump to some questions and just try to find a couple. I saw a great one about recredentialing, and one of your tips had said to maybe potentially include a prompt during recredentialing, and they asked what a wellness check-in prompt at recredentialing might look like.
So that might just be something like, making a policy where all physicians at the time of recredentialing are encouraged to either meet with the wellness officer or to schedule an appointment with their employee assistance program or to check in with the CMO, just to check in and see how they're doing. That's an excellent opportunity to just kind of monitor how people are doing in a very non-threatening way.
Great, great. I see a lot of comments in the chat about just commenting about scrubs. The scrubs program is great. Apparently Duke has a great program. Just sort of scrolling through to find some of our good questions. Kathy, if you want to just mark any and raise them for me, I can't scroll back far enough to find them. Let's see, what about URMs and burnout due to microaggressions and lack of mentorship? Good question. I know mentorship is a great topic we could talk about here.
Absolutely.
Well, I think we've covered most of the questions that have bubbled up. I know I was asking throughout the presentation, some that came up as well. So I think we will go ahead and thank everyone for being here today. If there's any unresolved questions, I will circle back to them and make sure to reach out to those folks. I don't see any. But thank you all so much for joining us today. Thank you to Dr. Thompson from the Hardenbergh Group for just joining us today and being part of this such great content. As I said to you earlier today, it's a topic we hear a lot, but you provide such wonderful, actionable tips and tricks and things that we should be pushing for. So thank you so much for presenting for us today. Thank you all for joining us. As always, it's our pleasure to bring you this information, and we hope to see you next time. Bye-bye.
Thank you.